Thank you for joining us, folks. We'll start a minute early, and I'm happy to announce the public comment version of public comment section of today's meeting. Public commenters have 2 minutes each to provide feedback to the council. We have 2 in-person public commenters today. The rest are virtual. So we'll start with David Hune from the Pew Charitable Trust. David, thank you for joining us today.
Thank you. Good afternoon. I'm the director for the Antibiotic Resistance Project at the Pew Charitable Trust, and I appreciate this opportunity to provide brief comments on the important role of antibiotics when it comes to protecting Americans from future pandemics, and to urge the Council to continue to consider creative policy solutions like the PACCARB Act that incentivizes the development of these urgently needed new antibiotics. As you all know, the COVID-19 pandemic has exacerbated antibiotic resistance and provided us with a stark reminder that any effective responses to future pandemics will require effective antibiotics. Unfortunately, the latest data from the WHO still shows a very stagnant clinical pipeline with a very few number of drugs that are targeting pathogens that pose the most critical and urgent threats like multi-drug resistant gram-negatives. These urgently needed drugs are not being developed in part due to a broken market for antibiotics that's acting as a disincentive for research and development for these important drugs. And as a result, the majority of the major pharmaceutical companies have shifted their focus away from antibiotic development. And today, small companies and nonprofit organizations are accounting for nearly 90% of the antibiotic candidates in the current clinical pipeline. The PACCARB Act, which was introduced during the last Congress, can be a significant part of the solution. It is designed to provide a very targeted lifeline for new and promising antibiotics once they have received FDA approval by providing a funding commitment that is based on, the amount is based on the drug's value for public health and delinking it from the volume of use. More importantly, the PACCARB Act is designed to award these contracts only to those drugs that have proven to address an unmet need in AMR with notable clinical impact. So we believe this innovative approach will strongly incentivize companies and investors to recommit their dedication into research and development of new antibiotics. The legislation also provides new grant funding for antibiotic stewardship programs, and as this council well knows, stewardship programs are critical to preparedness and response to public health emergencies and deserve and need a sustained level of research support. And then finally, the legislation is strongly bipartisan. It's supported by HHS in the most recently published White House budget a couple of weeks ago, and is endorsed by a very diverse group of stakeholders. And in fact, just early this month, the Pew Charitable Trust joined 230 other organizations that included healthcare providers, public health officials, public health professionals, and patients in calling on Congress to pass the PACCARB Act as part of the PAPA reauthorization. So I hope this council and all of you would join us in supporting this important legislation in the upcoming year. Thank you.
Thank you, David. Kevin Anderson, CARB-X.
Kevin Anderson, but I'm not here for CARB-X. I'd be happy to give a report at some future point of all the great work we're doing to restock the pipeline. I agree with everything David just said, but today I'm here on behalf of my role as a professor at Boston University. I'm the one behind the little handout in front of you, and I'll talk briefly about it. On the side that talks about the funnel, the 6 innovative new treatments, if you think how many antibiotics do we need, truly innovative, Pasteur quality antibiotics do we need in a decade? Here I've assumed 6. That's not a conclusion, it's an assumption. But if that's your assumption, if you want 6 per decade, not 6 per year, 6 per decade, what do you need behind it? And it's a lot of basic science projects coming out of NIAID and NIH, a fair number of projects that come through the red zone, which is where CARB-X is active, and a smaller number but more expensive projects in the blue zone at the bottom, which is where BARDA's phase 2, phase 3 program is active. The total cost on the left is about $12 billion. Now the good news, this is a global cost. The good news is that a lot of that is already being spent, of course, on all the work that's being done around the world, but hold that $12 billion cost in mind. And then focus on the far right, just the time frame, right? The number of years that's required. The things that CARB-X starts with today is 12 and a half years on average away from an FDA approval. So we have to work now for things that we're going to see in future years for approval. Turn it over, and this is data that I published in Nature Reviews Drug Discovery just a few weeks ago. And the red line, maybe it wasn't the best color choice, but the red line are revenues, global revenues of branded antibiotics, JO1 class globally. This is IQVIA data. And the green are the revenues from generic antibiotics. And if you go all the way back to the beginning of the data series, 1999, and look at 2001, 2001 was actually peak antibiotics for the branded products. And since then, we've had a remarkable positive public health news. Most of the antibiotics being sold, this isn't scripts, this is dollars, are today generics, which is a great access story for the planet. But I want you to know also that this means that the R&D engine behind the next generation of antibiotics has been systematically undermined because the companies are making less money. This is why the companies started leaving in the 2000s. And if you take the red line from peak antibiotic in 2001 and draw it across and solve for the area underneath the line, there's $150 billion of revenue that's missing from the last 2 decades. You know, if we had just continued to pay for antibiotics, branded antibiotics at the same level of 2001, there would have been an additional $150 billion of revenue for the companies. We wouldn't have a dry pipeline today. This is one of the evidences of why this is true. The gap today is $13 billion. So if you take the number I had on the other side, the $12 billion per decade, and remember, most of that is already being spent effectively. There's some additional money that's needed, but a lot of it is already being spent. $1.2 billion a year, okay? And think about Pasteur, the cost, you know, it's changed for a time or two, but let's just pretend it's $1 billion a year or $10 billion a decade. It's something in that range. So that's $2.2 billion, essentially, of revenues per year, a small addition, taking us back to maybe what we spent in 2016. That is the ask to restore the innovation pipeline. Not that we, you know, over-subsidize the companies back to some crazy levels, but just go back to 2016 or 2015 levels of branded revenues. That would actually deliver 6 innovative antibiotics per decade. Thank you for your attention.
Thank you, Kevin. Next, we have public commenters that are with us virtually. I'm going to call on Steve Roche with the Food Animal Concerns Trust. Steve, are you with us? Please be sure to unmute your line. There you go.
Okay, thank you. And thank you for providing me the opportunity to speak. I'm Steve Roach, Safe and Healthy Food Program Director for Food Animal Concerns Trust. As today's meeting is approaching its end, I would like to reiterate the urgency of the problem. Since we started this morning, at least 22 people have died from resistant infections in the U.S. Dr. Stack's presentation on climate, along with the discussions on fungal infection, were terrifying. At the same time, as patient advocate Mr. Berman stated this morning, the government's response to this crisis seems rudderless. We have committees and panels and meetings, yet the problem grows worse by the day. A clear example is the EPA approval of the antifungal iflufenquin for use on fruit trees, while azole-resistant aspergillus is killing growing numbers of patients. Was there no communication between EPA, FDA, and CDC during the approval process of this new antifungal? As described in our written comments, the FDA's response to the antibiotic resistance crisis can be characterized as sluggish and non-responsive to public health concerns, with decades of delays. Despite another government advisory body, the Intergovernmental Task Force on Antimicrobial Resistance, identifying the need for data on antibiotic use in agriculture as a priority over 20 years ago, no system is yet in place to collect this data. FDA in 2018 released a plan to promote antimicrobial stewardship in veterinary settings, but over the life of the plan, which ends this year, use climbed by 8% and resistance in food system isolates has increased as well. Even though the plan itself was not very ambitious, several of the target actions were not completed on time. Most disturbing among these was the failure to issue a final guidance requiring duration limits on the 30% of drugs approved for use in feed that do not have them. While the plan laid out many actions that FDA would take, it included no indicators to measure the efficacy of these efforts. One clear indicator would be that antibiotic use as measured in cells would go down. There should also be indicators related to antibiotic resistance in food system isolates. Food Animal Concerns Trust would like to see a new 5-year plan from the FDA that includes actual expected outcomes in terms of antibiotic use and antibiotic resistance. A huge gap in the original 5-year plan was a failure to set a goal to create a system to collect data on antibiotic use. The agency has used its own failure to put in place a use data collection system as a reason it cannot set use reduction targets, as has been done in other sectors. FACT hopes that efforts to increase monitoring and surveillance as part of pandemic preparedness would at least include on-farm surveillance of antibiotic resistance and antibiotic use. Thank you.
Thank you, Steve. Next, we have Louis Sokolow with the U.S. Public Interest Research Group. Louis, are you with us?
Yes, I'm here.
Thank you. You have the floor, 2 minutes. Thank you.
Sorry, I'm having trouble. I can't seem to turn my video on, but I can proceed anyways.
We can move on to the next speaker if you'd like.
No, sorry. I'll begin my comment now.
Thank you.
My name is Louis Sokolow, and I'm a Public Health Campaigns Associate with PACCARB. That's the Public Interest Research Group. And we're a nonprofit, nonpartisan organization dedicated to improving the quality of people's lives across the country through health and environmental campaigns. And I appreciate the opportunity to comment before the council today. As a member of our public health team, I work on our campaign to stop the overuse of antibiotics in meat production. And while we often discuss antibiotic resistance using stats, it's important to remember the individual angle. This is first and foremost a crisis that impacts individuals. I'm sure that most of the council and others watching today have confronted antibiotic resistance in some form. PERG runs a coalition called the Coalition to Preserve Antibiotics, composed of 80 farmers and health professionals dedicated to addressing this issue. And one of our farmer members in a webinar last month told a story about one of her lambs on the farm, which broke its leg. And when she went to the veterinarian to get antibiotics, she was told that she needed to use a dosage more than twice what she had hoped to use. And this is just one more bit of evidence that these miracle drugs we rely on no longer always perform miracles. Thanks to the council, we've made significant progress to improve antibiotic stewardship on the human healthcare side by reducing inappropriate prescribing and educating Americans about when antibiotics are effective and when they're simply not. However, given where this crisis is, we have to pay attention to antibiotic use in meat production, where almost 2/3 of the medically important drugs go. So here is what I propose that the council should recommend to Congress. First, set a target for reducing antibiotic use in meat production. We've seen this approach work in the European Union, which almost cut antibiotic use in meat production in half from 2011 to 2021 after setting such a target. And second, gather existing farm-level data like veterinary feed directives from feed mills to track progress towards this target and hold government agencies accountable for achieving it. I appreciate the council's continued leadership on this issue, and I urge more attention to be paid to antibiotic use in meat production to keep these drugs effective going forward. Thank you.
Thank you, Mr. Sokolow. Next, we have Min Min Yen with Phage Pro. We have you signed up for both public comment and the Innovation Spotlight. This is the public comment portion. You have the floor.
Hi, everyone. Thank you for the opportunity to comment before the council today. My name is Dr. Min Min Yen, and I am the CEO and co-founder of Phage Pro, a Boston-based global health biotech developing phage-based solutions for AMR in resource-limited settings. And why I'd like to use my public comment time here today is to advocate for a different way to develop antimicrobials. Our current linear product development model is not working. It requires high investment for research, development, and clinical trials only to be modestly priced after approval, and ultimately decreased effectiveness due to resistance. And the way the model is currently set up actually de-incentivizes investment and innovation, and subsequently access and international collaboration, especially with low and middle income countries. So what we could do instead is have an iterative product development model where the product is updated timely with evidence on resistance from surveillance data, just as we have done for flu vaccines and COVID vaccines. And I emphasize that we can be doing this by strengthening capacity for environmental surveillance, not only in the US, but supporting and coordinating efforts across the world to identify those resistance patterns. But ultimately, what we need is accelerated regulatory approvals of those modified products so that the solutions can then get to patients quickly, perhaps even proactively. And this really shouldn't be centralized in one country, but I do think that the US could be a leader in this effort that is global and coordinated, and ultimately harmonizes international regulation requirements because it affects all of us. So AMR, as we all know, is a nuanced and complex crisis, and it's not going to be one actor or one solution, but a change in our model for how we develop and how we update new antimicrobials to accelerate their development and sustain effectiveness is a critical strategy, and ultimately we'll be able to prioritize access. Thank you so much.
Thank you, Dr. Yan, and please be sure to stay on the line for the Innovation Spotlight component. Next, we have Ari Frankel from Arkstone Medical Solutions, also signed up for public comment and then Innovation Spotlight. This is the public comment portion. You have 2 minutes.
Thank you. Thank you for allowing me to speak today. My name is Dr. Ari Frankel. I'm a board-certified infectious disease physician and co-founder of Arkstone. We are a biotechnology company, and we provide innovative and intelligent solutions for infectious disease. In a few minutes from now, I will be presenting my technology, my company, and what we developed to fight AMR. But I wanted to take this opportunity to share my comments with you simply as a physician, somebody who's been out there in the field. It's great to see so many people join together for this important cause. One paramount element to address is the gap in antimicrobial stewardship. Having seen the overutilization of antimicrobials firsthand in rural America and seeing the alarming statistics, which include the fact the majority of counties in the United States don't even have access to infectious disease specialists, and that a fraction of total healthcare providers are fellowship-trained infectious disease specialists. The use of technology to bring evidence-based medicine is ever more important. During my time as a solo private practice infectious disease physician, I found myself as the only infectious disease doctor in 2 large counties serving approximately 150,000 people spread across 3 hospitals. It's hard to imagine that in the United States, access to essential expertise is lacking. But the reality is the needs of our community far outweighs our ability to deliver, unless, of course, we get creative on how we deliver care to patients. Many years ago, we couldn't imagine a world where our ability to access information from connections virtually and fulfill basic needs were as simple as they are today. There is a future where the same is true for medicine. As we have embraced technology in so many other areas of our lives, whether it's communication or transportation or how we receive data, the fight against antimicrobial resistance is no different. However, there's considerable pushback to this when talking with healthcare providers and healthcare systems. As a committed physician, like many other healthcare providers, I will stop at nothing to improve the lives of others and reduce suffering. And I want to encourage everyone to think of technology as a tool to enhance our ability to treat infections and embrace it as a mechanism of extended care and expertise with limitless abilities and boundless possibilities. Thank you.
Thank you, Dr. Frankel. Please stay on the line for the Innovation Spotlight component. Lastly, we have Jester Jersey. Are you with us online?
Yes, I'm here.
Thank you.
Okay, thank you. I want to begin by stating I have no pharmaceutical affiliations nor conflicts to disclose. Good afternoon to the Advisory Council, and thank you for allowing me to present. I previously worked with Kiwanis and UNICEF on the Eliminate Project, a joint global campaign from 2010 to 2020 to vaccinate women of childbearing age against Clostridium tetani, the bacteria that causes tetanus. During the pandemic and even the recent tripledemic of RSV, flu, and COVID, we not only saw low vaccine rates for the latter two, but also a lag in routine vaccine rates in general. Recent resurgences of polio and measles cases in the news demonstrates this concerning trend. Even if an RSV vaccine becomes available, if uptake mirrors recent vaccine trends, it may not be enough to prevent spread nor save lives. Whether a contagion has viral or bacterial origins, there needs to be a greater investment in trusted messaging to increase vaccine rates. As the COVID public health emergency ends in May, continued funding for immunization programs through the Public Health Service Act Section 317 is also essential to address future health concerns. In order to get those vaccines to people who need them the most, the federal government should work with local community-based service organizations. In 2021, U.S. Surgeon General Vivek Murthy said, trusted messengers are the key to boosting COVID vaccine rates. In January this year, Jagan Shapagain, the Secretary General of the International Federation of Red Cross and Red Crescent Societies, mentioned the important role community-based organizations have in pandemic response and preparedness. For this reason, I recommend that the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, the CDC, other Department of Health and Human Services Health Advisory Committees, and President Joe Biden and his administration to please reach out to community-based service organizations to collaborate on future vaccine campaign efforts. Together, we can encourage those who've missed routine vaccines catch up, increase vaccination rates, and protect Americans of all ages. Thank you for your time and consideration. Stay safe and have a nice day.
Thank you for joining us, Jester. And that concludes our public comment portion of the day. We'll now transition to the Innovation Spotlight, where startup technology companies or biotech companies with innovative products to combat resistance will showcase their products. First joining us in person is Dr. Nancy Tawil with PhageLux. Dr. Tawil, you have the floor.
Hi, everyone. PhageLux is a clinical stage biotech in the heart of the Canadian National Research Council in Montreal. Our innovative product portfolio is backed by patented technology nested in a One Health approach for resolving antimicrobial resistance. The portfolio consists of different formulations for the prolonged delivery of actives, such as bacteriophages and lysines at the site of action. Although our focus is on topicals, we do have formulations amenable to IV delivery, implants, and environmental decontamination, as well as products fighting cancer for which bacteria exacerbate the disease and for which antibiotics interfere with treatment. I'm happy to report that since we last met in 2019, our agriculture, food, and aquaculture divisions have been spun off into an independent and profitable company, with sales in the US, Canada, and Asia. Moreover, two of our human health therapeutics are under open INDs, and a clinical trial developed with the input of the ARLG is currently led by Mayo Clinic and the Miami VA. Next slide, please. Bacteriophages are the most abundant organism on Earth and the natural predator of bacteria. Because bacteriophages lack environmental stability and cannot be used as adjuncts to standard of care on their own, our goal was to encapsulate those bacteriophages in natural biodegradable matrix that will make them amenable to use as adjunct therapy, but also provide other important benefits, such as prolonged release at the site of action and faster wound healing. The polymer is constituted of amino acid building blocks with ester and amide bonds that will degrade using the increased amount of proteases secreted in the chronic wounds. While the free phages in the product will allow for the infection and lysis of the bacteria already present in the wound, degradation of the capsules will provide continuous release of these phages for the next 72 hours in between dressing changes. Our first indication is pressure ulcers. So pressure injuries are currently the only hospital-acquired infection or condition on the rise in the US, with 2.5 million patients treated per year in acute care facilities alone. The cost of treatment of these chronic wounds is high and exacerbated by the COVID pandemic and the fact that Medicare does not completely reimburse costs to the hospitals and the patients. On average, hospitals in the States lose $2 billion every year trying to treat pressure injuries. Phase 1/2 clinical trial will shortly recruit patients to evaluate the safety and potential efficacy of Bactolide. Development of Bactolide was in line with the fact that it's a global product meant not only for North America, but also for low and middle income countries. And so the cost of goods has been kept very low, and we are expecting to impact pressure injury stage transition by a minimum of 12%, thus saving hospitals about $10,000 per patient. Next slide, please. We also harness the power of bioinformatics to screen and engineer, test in a high throughput fashion gram-negative and positive endolysines. Our most advanced gram-negative endolysine is abumani, and our most advanced gram-positive endolysine is Cli-O for Staph aureus. And so in conclusion, I just want to note that AMR is no longer a silent pandemic, and while Big Pharma is pulling out or winding down its anti-infective programs, we turn to our governments for financing, infrastructure, and regulatory support to bring these new antimicrobials to the market. Thank you.
Thank you for joining us, Dr. Tawi. And next we'll go virtually. Eva Alcon and Dr. Malou on behalf of Médecins Sans Frontières. Are you there?
I am here. This is Eva Alcon. I'm not sure if Dr. Malou has joined.
I don't think she has, but perhaps you can just kick us off.
Sure. Started my video. I'm not sure if you can see me.
We can see you and
okay.
We can hear you.
Okay, thank you. So good afternoon. My name is Eva Alcon. I am a global health policy advisor with Doctors Without Borders, otherwise known as Médecins Sans Frontières, or MSF. Thank you for this opportunity to present an exciting innovation that's grown out of MSF's work to address antimicrobial resistance in low-resource settings around the world. As a medical humanitarian organization, MSF cares for people affected by conflict, disease outbreaks, natural and human-made disasters, and exclusion from healthcare in more than 70 countries. The places where MSF operates tend to bear a disproportionate burden of drug resistance because many of the primary drivers of resistance, as we've heard a number of times today, are especially present in low-resource settings, including lack of access to clean water, sanitation, hygiene, and medical care, lack of vaccines and appropriate treatment, limited laboratory surveillance and diagnosis, weak regulations on antibiotic dispensing, and poor infection prevention and control. MSF teams have directly witnessed in our projects alarming rates of drug-resistant infections, affecting war-wounded patients in conflict zones, newborns, and malnourished children, to name just a few examples. As a result, MSF has made addressing drug resistance a priority. Our interdisciplinary approach includes infection prevention and control, antibiotic stewardship, increasing access to microbiology and diagnosis, and health staff capacity building, among other elements. We've joined you today to discuss an innovation that was born of these efforts, and in particular, MSF's work to increase access to good quality bacteriological diagnosis. MSF has steadily increased its own diagnostic capacity in recent years, and in the course of doing so has developed some innovative strategies and tools with potential to advance diagnosis in resource-constrained settings more generally. We're excited to highlight one of these innovations for you today, the free, not-for-profit Antibiago smartphone application developed by my colleague, Dr. Nada Malou, a microbiologist and specialist in antimicrobial resistance. Before Nada begins, I'll just add that we in MSF's U.S. office, based in New York, believe that the U.S.'s National Action Plan, the way that recognizes the need for global collaboration to address drug resistance, is crucial to safeguard both global and domestic health. We hope that MSF's experience can help inform the continued development of the U.S.'s global work on this issue, and we're eager to engage with all U.S. stakeholders interested in addressing antimicrobial resistance around the world. I'll pass it now to Dr. Malou if she's joined.
Ms. Alcon, I don't think Dr. Malou has joined us. However, thank you so much for your slides, and we'll continue on, and hopefully we'll have another opportunity to hear from her at a future meeting.
Okay, I could do my best.
Keep going?
I could do my best to describe.
No worries.
All right. So, as everyone here is aware, access to accurate diagnosis is a key intervention for tackling AMR. Through MSF's experience establishing and operating bacteriology labs in low-resource settings, we found that training laboratory technicians to perform tests was easy compared with equipping staff to interpret test results, as this task is usually performed by clinical microbiologists who are frequently not present or available in low and middle income countries. We know that in order to reach the same level of capacity in sub-Saharan Africa that's currently available in, say, the US or Canada, we would need 400 years of training. Next slide, please. The interpretation that is primarily needed for antimicrobial susceptibility tests that provide a list of antibiotics that will and won't be effective to treat patients is the crucial skill that's lacking. Next slide, please. It's for this purpose that the Antibiogo app was created. It's a smartphone-based app that works offline and supports laboratory technicians in interpreting tests, even in the absence of microbiologists. Today, the app is a CE-certified medical device that's being used routinely in 5 different MSF laboratories. We're currently collaborating with regional partners on a phased scale-up of access beyond MSF projects, and our objective for 2024 is to make it available for any low and middle income country for use as a diagnostic testing, surveillance, and training tool. So thank you very much for your time. And again, we at MSF are glad to connect with others working to address AMR at the global level.
Thank you for joining us, Ava. I'd like to welcome back Dr. Ari Frankel with the Arkstone Medical Solutions. Dr. Frankel, the floor is yours.
Thank you again for the opportunity to address everybody. I am proud to be part of a team that is committed to bringing innovation to antimicrobial stewardship, especially to underserved areas. Unfortunately, despite efforts being made, there is a significant gap in antimicrobial stewardship. Currently, only academic centers or facilities with financial resources available are benefiting from antimicrobial stewardship programs. However, according to the CDC, a staggering 90% of antibiotic prescriptions occur in the outpatient setting, where antimicrobial resistance is currently antimicrobial resistance is present and antimicrobial stewardship is lacking or simply not existent. Furthermore, skilled nursing facilities where stewardship programs are required only account for less than 0.5% of the total population, making little impact on antibiotic usage. We've all heard the excuses: it's too hard, it's too expensive, it's impossible, it's too complicated. But the fact remains that to truly make a difference in the fight against antimicrobial resistance, we must focus on the outpatient setting, where the majority of antibiotics are prescribed. Arkstone has a solution, and allow me to show you a revolutionary antimicrobial stewardship. Next slide, please. What you see before you is a revolutionary one-choice report. Arkstone integrates directly with molecular and microbiology labs, and lab result data is transmitted electronically to Arkstone. Using artificial intelligence and extensive database of AMR data, the one-choice engine formulates a patient-specific plan for the treatment of infection. This is not just a lab report, it's much more, providing targeted treatment recommendations factoring the patient's age, allergies, pregnancy, diagnosis, the source of sample, as well as resistance and organism detected. Although medicine is a science, the practice of medicine can often become an art. When treating infections, physicians have to choose the right treatment options based on their limited knowledge and experience. This often leads to the wrong drug, or the wrong dose, or the wrong duration, or even treating microbes that are colonizers or possible contaminants. One Choice democratizes infectious disease knowledge and empowers physicians with important and useful information without drowning them in data. Physicians do not need to do anything more than order the lab result as they usually do, and Arkstone generates the One Choice report automatically, and the physician receives the recommendation together with the lab result instantaneously. Clinicians are presented with a clear treatment regimen that includes the optimal drug, dosage, and duration that treats the possible infection with the least chance of adverse reaction. One Choice recognizes commonly pathogenic microbes based on the sample source and often recommends no treatment at all when microbes are likely colonizers, contaminants, or self-limiting viruses. Molecular labs are testing for the presence of resistant genes, but physicians rarely know how to use that information in practice. One Choice interprets that information, making it clear what organisms can even express those genes and what drugs are affected by them, making the information actually clinically relevant. The proprietary ArcScore scoring system breaks down hard-to-understand concepts, allowing doctors to easily compare patients to each other or understand the difference between different antimicrobials. Physicians can add additional factors, such as the patient having drug allergies, or do a check for drug interactions. The physician can even access the references, the dosing information, the NIH statistics, and links to journal articles and reference material that back each One Choice recommendation. All this allows physicians to come to their own conclusions and make well-informed decisions that benefit their patients and reduce the overusage of antibiotics. The One Choice report is included as a paper document together with a lab result, and online, like the screen you see here, on a mobile phone via a QR code on the paper report. And this is a proactive, precision-guided medicine in contrast to a reactive approach. This approach assures that mistakes aren't even made in the first place. If we don't get on top of how antimicrobials are utilized, any advancements made in drug development will be hindered by rapid growth of new resistance. Next slide, please. On the left of this map, you'll see a CDC illustration on the frequency of antibiotic use by state. On the right is Arkstone's existing reach into those states. I'm proud to tell you that ARCstone is not a pipe dream. ARCstone is not hypothetical. ARCstone is proactively working to reduce antibiotic use in the United States. As we speak, nearly a third of our reports actually recommend no treatment at all. Think about that. Patients are going to their doctors, the doctors are running a lab test, and even though the detected microbes may not be pathogenic or they may be self-limiting viruses, many doctors still prescribe antibiotics. Many people today have even spoken about how patients often demand an antibiotic prescription from their doctors, whether they're actually in need of them or not. But now those doctors are receiving clear evidence-based guidance that they can share with their patients and hopefully avoid prescribing unnecessary antibiotics. This map also illustrates that ARCstone is a powerful surveillance tool. By integrating with dozens of laboratories across the country, we are at the forefront of detecting upticks in infection and resistant trends. We already use that information to help individual labs track trends within their patient base. But with further development and the right partners, we can use this data we collect to benefit the entire population. Next slide, please. ARCstone is living proof that outpatient antimicrobial stewardship is possible. Thousands of doctors and patients already benefit from the One Choice report, but so many more can benefit as well. We have proven time and time again to be an invaluable tool for practicing physicians, and our reach continues to expand. We are working with many of the leaders of the lab industry, including partnerships with lab machinery manufacturers. But there's so much more to do. Let's work together. Let's push antimicrobial stewardship programs and technology to account for all antimicrobial prescribing. Let's close the gap so that stewardship is not just for a fraction of patients. We have the technology to stay ahead of antimicrobial resistance. We've proven it's possible. Let's change the face of outpatient prescribing together. Thank you.
Dr. Frankel, thank you so much for joining us. I welcome back Dr. Mimi Yen with PhagePro. The floor is yours.
Great, thank you. And thank you for the opportunity to speak again. Thank you to the event coordination and technical support teams as well for making a virtual presentation possible today. Again, my name is Dr. Min Yen. I'm the CEO and co-founder of PhagePro, based in Boston as a global health biotech, developing phage-based solutions for AMR in resource-limited settings. And I greatly appreciate the emphasis during this meeting so far on international coordination and cooperation. And what I'm showing here is not a surprise to anyone in this room, the forecasted annual deaths associated with AMR in 2050 mapped onto the world. The darker the color, the more deaths per 10,000 people in the population. And as other speakers have noted before today, Africa and Asia disproportionately bear the fatalities. And we've learned so acutely and painfully during the COVID pandemic that our world is quite small and infections do not recognize borders. So if there's not a global coordinated effort to combat AMR, there are more chances for the organisms to evolve and come back even stronger. We've been stuck in reaction mode. So we need to make changes to our current system and strengthen and leverage on-the-ground collaborations to ultimately build a resilient, coordinated, and cohesive ecosystem that allows us to ultimately be proactive, which is much easier said than done. Next slide, please. So from a developer's perspective, what's our role in this fight? And I think the first challenge that every developer comes across is that there's a negative return on investment when it comes to novel antimicrobials. On average, it takes at least 9 years and costs about $1 billion. So for those who do get approval, make it to WHO essential medicines lists, and by all other metrics have developed a successful antimicrobial, the result is still bankruptcy because there are not enough sales on the other side to sustain companies. So how could we possibly even think about access and prioritize it when we are in survival mode? So as a small business, what can PhagePro do differently in this complex and nuanced crisis? And what can we do to rise to the occasion and meet these challenges? Our strategy and what we advocate for more broadly is to first prioritize access and find ways to accelerate development and thereby decrease these upfront costs. Next slide, please. We develop phages or viruses that specifically target and kill bacteria for unmet needs, particularly in resource-limited settings. So to prioritize access, we are formulating phages in a solid dose, and this has two important benefits. The first one being independence from the cold chain. Our phages will be stable in hot and humid environments and will not require -80, -20, or even 4 degrees Celsius for storage. And that allows for the second benefit, which is ease of administration and distribution. We need to keep it simple and convenient for patients and for healthcare workers. But even with all that innovation and technology, resistance is going to pop up quickly, and ultimately it needs a systems level approach in order for any antimicrobial to be sustainable. So we need to be conducting surveillance, and we need to be ready when that surveillance data comes back as a developer. Phages have the ability to evolve with the bacteria. They've been doing so for thousands of years, and we can harness that evolution and use it to accelerate development timelines when resistance occurs. That long 9 years can easily be shortened so long as we keep pace with these organisms as resistance develops. And if we can accelerate development, we can decrease that overall cost it takes to fight that resistance and keep the product sustainable and effective for patients. But we have to do that with stakeholder and partner engagement across the spectrum: patients, community leaders, healthcare workers, regulatory affairs, manufacturers. The list can go on, but it goes beyond traditional health departments. So as an example, our first product here at PhagePro is developing phages to disrupt cholera transmission. Cholera is an acute diarrheal disease that sweeps through countries rapidly, and the world is experiencing a surge in cases right now with higher case fatality rates than we've seen in 10 years. The WHO has stated that 1 billion people in the world are at risk. It itself is antibiotic resistant, even though it doesn't come up on these lists very often, and it lives in the environment with many other critical AMR pathogens. As an example of why a critical collaboration on the ground is needed, we've partnered with the world's leading diarrheal hospital, the International Center for Diarrheal Disease in Dhaka, Bangladesh, to conduct surveillance and keep a finger on the pulse when it comes to resistance and be able to update our phage cocktail as we go along. So not only are we building capacity and adding more resources, knowledge, and consolidating efforts across borders to leverage each other's strengths, but we're ultimately able to keep up with these microbes. And let's face it, we need all the teamwork and all the resources to just even catch up. Next slide, please. So to end, PhagePro, again, is working on iterative product development, which we believe is not only critical for phages, but any microbial. And it has to be informed by on-the-ground partnerships with stakeholders and patient communities from the start, because once the innovation hits the field, it needs to also be accepted. It can't just be approved and given to the community and assumed that it's going to be used. So as developers, we can be as efficient as we can in accelerating development, but we need help from the government to actually get it to the people. As our antimicrobials are updated to combat resistance, again, regulatory review is the biggest thing that needs innovation. It needs to be accelerated in a way that still maintains safety, but reduces timelines so that developers can respond to resistance timely and ultimately be able to save our patients. If we do it for our flu vaccines and we did it for our COVID vaccines, there must be ways that we can sustainably do that for the many diseases that comprise AMR. And from an access perspective, this will allow access from low and middle income countries to easier access all the innovations that we've been talking about in the US and have been presented today. The US can be a leader, and it needs to be a leader on the global level to prioritize AMR on all the different government agendas and coordinate strategies across borders. Thank you for your time, and thank you all for listening today.
Dr. Yan, thank you so much for joining us, and a sincere thank you to all of our public commenters, folks that have sent in notes to our PACCARB at HHS.gov that are available in print, and you can email us if you'd like to see copies of those as well, and to our Innovation Spotlight companies for joining us, for those of you in person and virtually. We're going to transition now to our round robin, where we'd like to hear from all of our council members. Before I hand it over to Dr. Blazer, I just want to emphasize that these are not considered recommendations on behalf of the council. This is purely feedback and open conversation in the interest of transparency, and just opinions that are provided by all of our council members. We also invite our regular government employees to participate in this portion as well. Dr. Blazer?
Thank you very much, Dr. Musmar. So now we come to the portion of the meeting where everyone on the council, everybody sitting at the table, whether they're voting, non-voting, or government member, can opine about the world. And in particular, our challenge today is that we have pretty much complied with the recent ask by the Department of Health and Human Services with the report that we're going to vote on tomorrow. So we have kind of an open agenda. And the question is, what should we do next? What are the issues that concern people where we at PACCARB can make a difference? So we're going to go around the room. We're going to start on my left. Dr. Simczak will be the first, and we'll just keep going around until we finish. I look forward to what everyone has to say. Thank you. Dr. Simpson.
Thanks so much. Today was, again, a really wonderful, informative, and educational day for me. I think there are 2 points that I wanted to make based on what I heard today. And the first is kind of something I think I would like to hear more about for the council to consider more is the sort of, I don't know if it's a tension between action versus evidence generation and sort of how much evidence do you need to act? I don't know that it's an either or, but to me, that's an open question I'd like to think more about, particularly, from the patient story that we started with today and sort of how much do we need to know to be able to do something, and thinking about barriers to action. I was really struck by Dr. Fukuda's talk today. That really made me think a little bit more about, one of the barriers that we hear, to changing things has to be related to a lack of political will or ownership of these issues. And as I was listening more today, I thought it may not be so much that people don't care, but that they are needing to manage complex competing priorities, and that this is just one of many other priorities that people are urgently trying to solve. And so how do we integrate that insight into what we do, the recommendations that we make, acknowledging that we are all deeply invested in this, but it's one of many other issues that are kind of competing for resources and attention. And so how do we construct the problem of AMR and the solution space? Thanks.
Right, I too enjoyed the presentations, and I think one of the topics that kind of comes to the forefront for me as we end the day, we've talked several times about the One Health, quite a lot of the day, about the One Health component of antimicrobial resistance. We've talked some about the economics of production or development of new antibiotics as well as alternatives, the economics of use. We've also talked about the need for new alternatives in the space around agriculture, whether it be crop or livestock, and then the issues in water. And so I think that's a space that we need to continue to explore. In the work that we've done unpublished, we see somewhere between about a 45-to-1 to 100-to-1 ratio of investment in alternatives and new options on the human side versus the agricultural side. And so in no way am I implying that we should reduce that in the human side, and would advocate, as we have throughout the day, for increased funding there. But we have talked numerous times about the importance of how that use in agriculture and in the environment also impacts that human side. And so I think our investments and thinking about how do we make critical investments in addressing that so that we can continue to identify those alternatives that ultimately can allow us to be better stewards on the agricultural side while maintaining food security, and then impacting human health as well.
One thing that I heard today that kept coming back and we've been focusing on so much is communication and concrete takeaways. So I think one thing that I think maybe we could all commit to, and maybe everyone in this room, is having some sort of concrete takeaway to help educate the public. I heard a lot of that from the comments today from our speakers, whether that's an op-ed, whether that's saying yes to a media request, whether that's really making a toolkit to give to your patients. I think that's actually something concrete that we could definitely all do, and actually goes to educating the public, which I think we all agreed today was something really important.
Yeah, great. Another great meeting this today was, and learning a lot from everybody. I walked in thinking, to see what the agenda was, and the notion of we're talking about the environment, we're talking about water, we're talking about crops, and a person that's been in pediatrics who initially came in thinking about just humans, little humans, one might say. And that has over the years changed a lot as I've met my veterinarian colleagues, those that are in food production, and how complicated it is. And it really gets down to antimicrobial resistance is extremely complicated and is not as simple as an antibiotic leads to antimicrobial resistance, as we heard today. And there's a lot of stuff I think has to get down to some of the foundational pieces of just our society, whether it is making sure we have clean water, whether we make sure that children can be nourished and not be malnourished, because we know malnourishment, you get a disease like measles, you can die. which gets to some of the prevention things. And I would hearken to really the public comments that we got to hear from Mr. Jersey, who called out and says we need to vaccinate better. And vaccination is a preventative efforts that can be done, and we need to do more of it. And I think that's what, in 2024, I think vaccination, the notion about vaccine innovation, the notion about how do we get more people vaccinated, and how we continue to address that, because that's going to be a major issue moving forward. And thank you very much for another great day.
Okay, it's working, right?
No.
Oh, you said it got fixed.
Yeah, I don't see the red light.
Oh, the red light's on. Anyway, okay. First, I just want to say I'm rotating off, and I want to thank you for this wonderful opportunity. It was fantastic. And I learned so much, and we all get more than we give, clearly, for this. And like all rotating members, call us if you need us, okay? I came away with 3 sort of next steps from this meeting. We've done a lot, but I want to build on what Julie said, and that is that, and also what Dr. Fukuda said, which I thought was terrific, and that is that somehow we have to move to institutionalization of AMR as a priority in systems of care. And at the same time, we need to integrate and link AMR and other priorities and agendas rather than treating them as a separate entity. So we need to figure out how to integrate it into the culture. So that's one thing. The second thing is that I think we could, I think it would be helpful as a next step for somebody to focus on implementation, specific implementation strategies for the AMR written recommendations and guidelines that have been promulgated by a lot of societies, by CMS, by CDC, by various things. We have all these policies, procedures, and guidelines written now. They don't all agree, but in general, the principles are the same. And yet, it just doesn't seem like they're getting implemented. So writing a policy isn't enough. So that's sort of the third thing. And then this is probably more of a personal interest, but it relates to what Payal said, and that is that we need to arm and motivate our clinicians to help educate their patients and other people about antimicrobials and their prudent use. Not only let's give this to you just to be safe and make sure we don't have any risk, but also what are the downsides and how can they contribute to their own health care to, to try to avoid misuse of antimicrobials.
So we got our light working now. So I, from my perspective, from a veterinary perspective, I think one thing I'd like to say is really, as my time draws to a close on the committee, I've been struck by the willingness of this group to learn from each other and have discussions about the complexity of this issue and dig into what those complex issues are. It's a strength of this group, and I hope it's something that continues. It's very important, and the unwillingness to oversimplify something that's really complex just for the sake of expedient recommendations. So I think that's been a great strength. It's something I've appreciated, and I hope that continues. Continue to include VetMed and in all the aspects of AMR and AMS in terms of funding, research, discussion, policy development. As we try to figure out how to affect behavioral change, what I'm struck by is our issues on the ground are a lot more similar than they are different in terms of what drives decision making. And so that makes me optimistic that there are solutions out there, that maybe the complexity there is something that's manageable and something that we can make progress on. Continue to explore the peripheral impacts really to the hard science. We've talked about communication and access. I think that's been very insightful. From my perspective, labor's the next big issue. It affects our ability to get anything done literally in the field and on the farm. And we've undergone a seismic change in our agricultural workforce and also in the technical support of that workforce in terms of veterinarians and other professions that are involved. And so I think there needs to be some discussion. None of this works without people to apply the intervention. So we've got to keep building human capital. We've got to figure out how to maintain that pipeline with the same urgency as a drug pipeline as we move forward in the future at every link really in the chain. So thank you.
Thank you. I want to echo that from others. I've learned a tremendous amount on this council, and especially about the work of my colleagues in other fields, especially animal medicine. It has led to new links that I think will help advance our fight against AMR, including our own Society of Infectious Diseases pharmacists joining NAMRI with Dr. Plummer. And what I would like to challenge the group to think about going forward is, as we heard so many times today, especially around the example of a new antifungal that's already being used in crop production, I think that we need to start looking at ways for novel drug development. We are doing animal studies, human studies, and crop science studies on the same compounds to develop new agents. We talked about the need to steward these together, and I think if we could bring organizations and our federal partners together to develop streams and pathways that we could share some of that work, we would get towards the goal of lowering the cost of drug development, and we might allow a more productive approach to how we launch new drugs in all three sectors. And so I think that's something that perhaps the PACCARB could do, having a successful track record of bringing all these elements together. Thank you.
Great. So first, I'll also echo the thoughts of many that I've learned so much, and particularly in the different areas outside of human health that we can bring to kind of broader AMR awareness work. I'll start with an observation, then a recommendation, and then more of a general comment. So first, this morning, Ramanan spoke about the need to horizontalize AMR to ensure it's understood and tied to all constituencies. And then I heard a similar theme when Libby was speaking about focusing on being a lumper, not a splitter, and underscoring that what we need to do is not necessarily have the public focus on Candida, then Shigella, then contaminated eye drops, and then choose your pathogen du jour featured in the media prominently that week, but more understand, desperately, we need the public to understand that all those things are connected, and they're connected to antimicrobial resistance and to AMR more broadly. And I think both Ramanan and Libby's comments, they tie closely back to the importance of communication, effective communication, messaging, and raising public awareness. We dedicated a large portion of our last PACCARB public meeting to communication as well. I think we've made really good progress on this front as an AMR community, but there continues to be work to do there. So now a recommendation, no surprise, tied to communication a little bit, being that if the council is able to approve and finalize the fabulous report that we've been working on over the past months, I'd strongly encourage PACCARB to develop an accompanying media plan of some sort, and potentially a social media kit or communications kit to have it be easy to share among AMR stakeholder organizations, both within the federal government and outside, to have those strong recommendations that the council's developed able to be communicated outwardly and seen by broad audiences. I think we talk about the development of a whole host of reports, and sadly reports gather dust on shelves, and whatever we can do to make that not happen moving forward, especially with these strong recommendations from the council, I think would be really wise. Then the last point, with encouragement from Dr. Blazer to talk about the world, I'd like to underscore again some of the themes from several presentations today that underscore the fragility of the antimicrobial ecosystem and really the need for incentives to provide the reinvigoration of the pipeline. And I think as it relates to policy, it would be wise for the council to think about if and how the council could build on previous work, examining pull incentives or other policy recommendations across animal health, agriculture, and human health.
I commend the PACCARB for really trying to look at One Health, and because this meeting's example that we looked at the environment. But that's not the only time we've done that. There's been several meetings about that, and I commend the committee for trying to struggle with the complexity of bringing the environment in. One suggestion I would have is that if we really do want to embrace the One Health concept, we should bring in stakeholders that represent the industries that protect the environment. For example, the wastewater, drinking water industries, they have nonprofit organizations that represent them. There are groups that represent the clean water regulators across the country, not EPA, but more at state level. And that, I think, bringing them in as stakeholders adds to the breadth of the One Health focus, because you're really bringing in the people who are going to be trying to mitigate some of those impacts in the environment.
Thank you. I'm Chelsea Shively, and I represent USDA APHIS. And I am a veterinarian, and I look at this issue through an animal health lens. But I really appreciate the inclusion of the environment today, because we don't always actively think about the environment when we're looking at antimicrobial resistance. And in my agency, we have plant protection and quarantine. We also look at wildlife species, and we touch the environmental component in a few different ways. So it was really great to hear some presentations on that topic. When I look at the council, there's many experts sitting around the table, but I think one of the greatest strengths of PACCARB is really the connections to all the different stakeholders that we represent. And so I would ask that the council reach out to those stakeholders about the future directions and where we should be going. The CARB Federal Task Force will be starting our next round of the CARB National Action Plan for 2025 through 2030. So it'd be great to get some input from the council as well as those various stakeholders moving forward. And I just want to reiterate that we need to continue to understand risk and really look at those areas that we can have the greatest impact. So thank you.
Great, Chris Houchins from BARDA, and I really appreciate today's session. You know, it's kind of the environmental impact of AMR is not something I honestly think about a lot, given my role in more advanced development of medical countermeasures. So it was really great to, I would say, be educated today, and really appreciated everybody's comments, thoughtful comments, and expertise that they provided. I have to say, and I apologize that I had to step out for the last 20 minutes, so I apologize if I'm stepping on any other suggestions or recommendations, but one of the things I was really struck by was a comment from Dr. Fukuda this morning about how, you know, we really need to think about, as a community, how to integrate AMR into lots of other problem sets. You know, is that we need to elevate the presence, the issue, the challenges of AMR, especially as we've been talking about, you know, the environment today, and integrate it with other, you know, other issues in which people can really grasp and really have a much better understanding and comprehension that it's not just about antibiotic resistance, but it really is about more of a larger global issue. And I think being able to do that, being able to integrate this, you know, the challenges that we're facing with the larger global challenges of, you know, environmental protection, you know, chemical pollution, things like that, I think might help to elevate and sustain visibility in this space. So it's something that I'm going to be left with today, and I think it's something that we need to think about how we can do this with regard to messaging, but also with regard to policy. Kind of going forward, one of the things that I've always appreciated more than, not more than anything, but really value is the patient advocacy perspective, you know, that starts off all of our meetings. I think it always helps to set, you know, not really just the stage, but mostly the tone for what we do for the next 2 days. And I just wondering if the committee has a way to amplify what we hear during those patient statements, those patient advocate statements. I was at a meeting yesterday on a different topic on antiviral development, but also in that space, kind of the patient perspective was identified as one of the critical gaps with regard to messaging in terms of you know, ensuring that the appropriate visibility and support is there for that space. So I would really ask the committee to think about, are there ways that we can really amplify those comments that we hear, perhaps help to establish a larger constituency, which then could really support a lot of the efforts of the committee as well. So thank you very much.
Hi, this is Kyungmoon at NIH, and I'm here for Dennis Dixon. And just echoing the other members, what other members already mentioned, the meeting has been great and very informative to hear speakers on AMR issues, on environmental, from the environmental perspective, including clean water and wastewater and climate change. And I would like to simply kudos to all the speakers. Thank you.
Hi, Melissa Miller from the Agency for Healthcare. Okay. Melissa Miller from the Agency for Healthcare Research and Quality. Just a general comment and then a couple of specific comments on communication. My general comment is, as AHRQ focuses on healthcare delivery, this is, not an area where I spend a lot of my time thinking. So it was really good to hear all of the presentations and discussions today. My mind's been opened. I'm probably going to have nightmares tonight with all the apocalyptic scenarios that came up this afternoon. However, very educational. I was actually able to bring home a couple of, concrete things that may affect my work in the next few years, and it's much appreciated. As communication reemerged, and to echo some of what my colleagues said, a few things pop up for me. The importance of specific stories, and I kept flashing back to 2006 when I was an infectious disease fellow and having to write a note on a surgical patient that we had nothing more to offer. This is at the request of the attending, but the rest of the team was not on board and just shocked and angry that there was no more antibiotics to offer. Those are the stories that I think need to be told, and they're probably occurring a lot more often. And I'll say one specific story that I heard in the media that was effective for me in the past week was the loss of eyeballs related to the infected eye drops, and that image is impactful. So specific patient stories, I think, are important. And then following up with concrete steps, and then somehow tying in, the global efforts. I think this is our challenge, but also our goal. And to echo what Dr. Larson said, I feel like I'm receiving a lot more than I'm giving today. So thank you very much.
I'll echo that too. My name is Ruby Shower. I'm the alternate to Bill Flynn. I'm from the FDA, from the Center for Devices and Radiological Health. My specialty is antimicrobial susceptibility and resistance. Thanks to everyone who participated in the presenters. It was really great and eye-opener for me, like everybody else said, the holistic approach of the impact of all of this. A couple of things I want to say, hearing actually our Canadian colleagues, so thank you for arranging for that. And they gave several nuggets, I think, to follow. One of them is how they made some distinction about the action plan and the implementation of the action, and how to measure all of that. So that's actually one thing that could be taken forward. And the other is the importance of surveillance was highlighted, still is highlighted. But again, I think approaches, unified approaches, standardized approaches will be excellent way to understand that more and better, because if you're doing surveillance for just the environment and surveillance for also isolates from infections, whatever, all of that can come together in our understanding of antimicrobial resistance. And lastly, I'm really glad to have heard the innovation spotlight. There are some things there that merging multiple technologies together could also be extremely helpful in addressing AMR. So thanks to the council, and thank you for the opportunity.
Good afternoon, everyone. I'm Gamal Winberry, and I'm representing USDA FSIS today.
Can you move the speaker closer?
Thank you. Again, I'm Gamal Fortenberry, and I'm representing USDA FSIS today. Thank you for the opportunity to join you and to learn. I really appreciate hearing about the environment and AMR. One thing that has my mind really turning today is the comment that AMR is global and complex, but the patterns are local. And just one general comment is that I hope that we keep this in mind as research and mitigation strategies are developed and as we are engaging and informing the public. Thank you again.
Hi, I'm Paige Waterman representing the DoD, and I guess I have two comments, and really they they sort of mimic what's already been said. But Melissa spoke about the eyeballs. If we saw a news story today about, a wide body plane crashing, we could all imagine what that means especially even if you didn't have a loved one on the plane. But I think the trouble with all the discussion that we have here, the wonderful discussion, which again, I think Emily mentioned, is how do we convey that to people, right? So whether it's the council developing a toolkit or a media kit, we have to be able to get all of this wonderful communication and adapt it to the different audiences. So those audiences could be the policymakers, it could be the product developers, the innovators, it could be the healthcare providers, the general public, right? And any of those people, by the way, could be subject to having an AMR infection. And doing that will help generate that political will, which is what really started all this process off a number of years ago, at least in this country. So again, I'm just reiterating the need for sort of our messaging. And I think the council can take a lead in that with all of the great staff and input that you have. And then my other comment is also maybe redundant to what folks have said, but I hearken to what KG said and what our Canadian colleagues say. And I remember how all of PACCARB started, and our Canadian colleagues said, they don't have the B, like they're not limited to bacteria, right? So we have that in our charter. But I have seen over the years, we talk about today, it's very much One Health, looking at fungus, looking at wastewater. We are more powerful, right, when we work together. So the linkage is more powerful than working in the silos. So thanks.
And I apologize in advance because I do have to run to a phone call right after this, but I did want to get in a word. So I will just note for a preview for tomorrow, Dr. Maria Walters, who led that eye outbreak, is giving a presentation to the PACCARB tomorrow. It is quite compelling and also quite frightening, and I think puts a lot of new issues actually on the table that we have not really faced yet. And, to that point, in terms of areas of future need or exploration for PACCARB, I think a couple that come to mind are doing more on global and getting a sense of what is happening around the world. I think we have touched on that, but I think a lot of this has focused and been very U.S.-centric, which I think is appropriate, but I think we're also getting into some context where we do have to have a better sense of what is happening with our neighbors and overseas, and what the movement of individuals and products and people and animals and the impact of the environment is actually doing with the ecology of resistance. The other aspect that I think is an important one, and it's been touched on by a couple different folks, but I think we do need to also look at alternatives and prevention. So I think we've talked about some of those at different times, but I think more conversations about the importance and power of vaccination. I think the importance and power of alternatives to antibiotics, decolonization. We can't decolonize the globe, unfortunately, but we can, I think, get to a point where we can potentially decolonize and lower the risk of infections in humans and potentially in animals as well. And I think those are areas of needed exploration. Thanks.
Carla Houston, representing the American Association of Extension Veterinarians. And as a liaison, this will be my last meeting, but I wanted to thank you all because this is a great panel of experts, liaisons in all different, many disciplines. And I'm going to mimic what many of you have already said. And coming from my perspective as a veterinarian who does research, education, and I produce cattle, I want to remind the committee to make sure that we take these high-level applications and the science and the research and not forget about the local applications. One of our meetings, we talked about emergency response and disaster response. And I think our first speaker mentioned our crisis is here. And we've got to remember that, when we have a disaster, when we have a crisis, we've got regulations and we have government workers, but at the end of the day, who's left to manage? It's our physicians, their clients, our veterinarians, their patients, and the farmers. So as many of you have already said, keep those communication lines open, do a toolkit, a communication toolkit, and make sure that we've got that whole continuum of people involved so that there are no gaps in communication. The message, of course, cannot forget about prevention and vaccines, but also, at least with animals, the way we manage people, the way we manage livestock, the way we manage animals. So that's my first point, is not to forget that whole continuum of the high level conversations versus the lower level. I don't want to say lower level conversations, but kind of the local grassroots stakeholder conversations. And the second point I would like to make is don't forget about the momentum. I think, Libby, you said the chicken nuggets. We totally relate to chicken nuggets, right? One of our speakers talked about hurricanes and natural disasters. You know, you hate to take advantage of it, but let's keep that momentum going. We also mentioned fungals, and something that nobody's mentioned is that fungal infections in animals, especially small animals and equine, is a huge concern right now. Jump on that momentum and use that to propel our messages. Thank you.
Hi, everyone. So Stephanie Black. I think with the angle on representing urban local public health, I do want to thank the opportunity for being on the council. I have been sort of gobsmacked at the idea of taking complex issues and making recommendations that can lead to policy change. And I've really learned so much so far being on PACCARB, so much appreciation for that. We made it almost all the way around the table without the comment about dropping the B, but I agree with the refocus on really including fungal infections. And I do think I fall more maybe on the splitter side, because I do think these individual patient stories, as many have said, are so critically important. And I also think with fungal illness, there's also opportunities for infection prevention and control. You know, we make a big deal about not having fountains related to Legionella in healthcare settings, but we also must not have plants, you know, in areas in the cancer centers. And I've seen this, you know, looking into mucormycosis investigations. So I think those are things that PACCARB can lift up and are important aspects. And communication, I do think we could use some Gen Z, kind of what Emily was saying, like getting some social media toolkits. Looking forward to getting the AMR message out there. Other ideas, two more in terms of looking forward. I am very interested in the idea of this integration of multi-layered data systems to inform disease burden. So combining, you know, wastewater surveillance, you know, and other sort of with whole genome sequencing and other areas we have, and this is discussed in our report, which will be formalized tomorrow. So I think that that's an important idea to inform disease burden from more angles. And then lastly, I do want to reiterate this issue of race equity that we want to keep in mind as we discuss all issues. And with Jason Newland had mentioned vaccine, I want to just mention the idea of vaccine for adults. Vaccine for children is a way to get underserved kids vaccine, but there isn't such a thing for adults, and I think that is something that we should keep in mind. And so I'll turn it over to Dr. Jenks, who will certainly say a similar comment more eloquently.
Thank you, Tim Jenks, Wellcome Trust, and it's true. I think I will be repeating much of what's already been said, but I hope that I will at least be reinforcing these important statements that we're making around the table, and maybe cast some light on a couple of aspects. So today, you know, the environmental dimension of AMR is very important. It helps us understand better the sources and drivers for AMR and how that can create worse impact in communities and for people and public health overall. So that's really good that we've brought that forward, and it shines some light on the complex system. Though the complex system thing often becomes a problem here and an excuse or a reason for inaction. And I'm going to touch on one of my recommendations related to that. Today we heard about geographic variation, though, and this is really important. But Dr. Black here just pointed out the important issues related to social variation as well. Will come up tomorrow, but I don't think we can say enough how much this matters. It's about people, and people's circumstances are quite varied with respect to the impact of AMR and infectious diseases more broadly. And I think we need to be clear that we're providing recommendations not only about how local action is important in places, but about people and communities. And the risk of overgeneralization creates some massive gaps in the impact that can be had overall with this. It was really great to hear what Dr. Fukuda said. We must see joining up with other agendas. AMR, as a scientist, is biologically really exciting. As a public health thing or something for the public, maybe not such an exciting thing to get your head around. But the key thing is, how do we make sure that things get done? Joining in with the other agendas is an important thing. And as we heard today, really the big issue is about identifying priorities and how can prioritization be done, better risk assessment. The thing that strikes me overall is not how important AMR is as a crisis to be addressed, but actually the shocking implementation failure. We know and have heard solution after solution after solution, and frankly, too few are being implemented. And this is something that as a group, PACCARB can do more to help drive action further so that implementation can be achieved overall. And part of that certainly has to be in understanding the risk assessment to prioritize and have prioritization that is locally led and locally understood. I like what Dr. Carragher said, that with this complex issue, it's been good that PACCARB has avoided simplicity as an expediency. But nonetheless, I think a role of PACCARB is actually to tackle this very difficult issue and synthesize the complexity and make recommendations that simplify the options for solutions. So I don't think that it's good enough to let this complexity tie things up in action. And lastly, I want to say that it would be good if we could articulate a preventative strategy. So prevention isn't just about vaccines and vaccinations, and actually it has a component in relationship to therapeutics and treatments, and certainly antimicrobial stewardship. Can PACCARB better articulate a preventative strategy so that AMR can be controlled over the long term? And while I'm going to cheat, the fact is there is a burning platform issue, the fragile pipeline. It's important that there are solutions that are delivered, investment and incentives done by the government as soon as possible. This risks undermining all the progress that's being made and knocking us backwards and not being able to deliver an overall agenda. Thank you.
Christine Giannacchio, Quotient Diagnostics. Great presentations today, and I really enjoyed focusing on the environmental portion of this. I think everybody knows the buzzword of One Health, but most people only think of One Health as it pertains to human health. You may know a little bit about animal health, but environmental health is really a point that I think we need to do a lot more work on, education, the public. And I was really impressed, I have to say, with the programs that were presented today that I was not even aware of in the environmental health world. And I think that's been really a tremendous progress. But yet at the same time, we need to really strive to make everything cross-functional. We tend to silo ourselves into a little bit of our own groups in our own comfort zone, whether it's human medicine, veterinary, or environment. And I think we're at the point now where that interaction is getting better and better, and I think we have to push a lot further for that. One of the other points that was made by the group today, and this really relates to environmental education, information for the general public, was a comment made about safe drinking water. If you polled people 100 people, what is safe drinking water? What does that mean? It means that there's no carcinogens. I grew up on Long Island with the highest rate of breast cancer in the entire United States because we lived on farmland that was developed and they used DDT for dozens of years, and we have all artesian well water. So that's what a lot of people think about. Or they think about, if I drink contaminated water, I'm going to get salmonella, or I'm going to get a viral infection, and I'm going to get physically sick. But one of the concepts that I thought was really key brought up today, that even in what we would consider clean drinking water, is the fact that coliforms are there that could be carrying these AMR genes that could colonize our gut. And maybe it's not going to make us sick today, but if you have cancer, chemotherapy, or you have something that goes on, that these organisms could play a really severe role in your care later on due to antimicrobial resistance. So that was just something that popped, I thought was important. And then the last part, which I asked about earlier, I'm still having a really hard time in figuring out how can we make now we want to silo, let's put it. The other way, we don't want to silo. Now we need to silo. How do we separate human drugs, veterinarian drugs, and environmental treating agricultural crops? I think this is just the road to really, really failure as we move forward if we can't figure out how to segregate those, how to come up with alternative solutions for maybe agriculture, different ways that these drugs cannot be used across all these 3 different areas simultaneously. So I think that should be, I don't have a solution, believe me, but I think that to me, would be one of the critical things that I think I'd like to see PACCARB on maybe a separate task force to figure out how we could make some recommendations to really kind of address, to me, that issue. I've seen lots of patients with invasive fungal infections and, in our big transplant units, and they die really fast. So we're at a really critical point for that. But I'd like to thank everybody. It was a great session.
Hi, everybody. My whole career, I've always wished I knew more about the environment and ecosystem health. Today, with the wonderful presentations we had, only intensified that feeling, and it added a huge dose of humility. We seem to be pretty early, at least for me, for sure, in our understanding of the importance of AMR in the environment. Dr. Fukuda asked what proportion of this issue rests in the environment. And then it started thinking about this, and when the Canadian presenters, who said so many interesting things, said that Canada has lots of snow. And that struck me because when we think about the environment, we kind of put it in a black box, like it's one thing when we're talking about AMR. But the environmental survival and the transmission dynamics of antimicrobial resistant microbes and genetic components would be very different, of course, in Canada than on the equator. And I just feel like the complexity is so great, and that would be one area that we could be looking at in the future. And Dr. Stack said that AMR challenges must be addressed as systems. And of course, ecosystems are one of those systems that needs to be involved more and understood better. And of course, again, back to the One Health. One big lesson today, for sure, is that we do need to involve the environmental perspective more assiduously in our One Health approaches to problems. In veterinary medicine, of course, we think that if you involve human health and animal health, then it's One Health. But it's not really One Health until you're talking also about the environment. And One Health without the environmental component has really limited applications going forward. In terms of, I should have said I'm Joni Sheftel and I represent the American Veterinary Medical Association. I don't want us to lose track of stewardship and infection control. And one of the things about stewardship that I think sometimes isn't understood by especially members of the public is that it's about a lot more than judicious antimicrobial usage. It's about figuring out all the different ways to avoid the use of antimicrobials. And in the AVMA's definition of stewardship, there's some core principles. And one of them is to advocate for a system of care to prevent common diseases. And that's so simple, but so important. And another one is to to educate and build expertise. And I guess that's part of what we do here and what we'll continue to do in the future. Veterinary infection control is a really big issue right now, and we can't forget about that one either. We have in my group at the Minnesota Department of Health, we have a veterinary technician who's our veterinary infection control expert, and there's so much work to do in various areas of veterinary medicine with rehabs and whatnot that came to life during COVID and also high-path AI. So thank you for the opportunity.
Hi, everyone. So it's been a real honor to be on this council, and I guess like Mike and Marty and Helen, we've been here from the beginning, and it's kind of sad to rotate off because it's been fun having these conversations. The team, Jumana, the entire team is so amazing and has done such an amazing job, and you'll see that, of course, with the report as well. But I was just sort of reflecting on things that I thought we'd made progress on generally on this issue. I was involved in the PCAST working group that then led to the PACCARB and this committee. But even prior to that, in the early 2000s, and I think only Dennis over here was part of that world. He's not here now. But, the interagency task force on AMR was so small and so underfunded, they could afford to meet once a year in the dinky Hyatt Regency next to Bethesda Metro, because there was some other meeting there, they'd all show up there. And then we had a small meeting room. And I was just thinking, wow, we've come so far. And all these agencies put together couldn't put up, I don't know, even $1 million to do anything on AMR. And I remember, we had a grant from RWJF and we got to pay for a CDC meeting at CDC because CDC had no money for AMR either. And to think that in that period of time we've come really so far is just mind-boggling. Of course, the problem was always there, but we just never managed to get traction all those years. And of course, things changed in 2015. And I want to reflect that, things really changed with President Obama, him very personally. And it was very personal because I remember when this PCAST group was formed, there was no money to run the group. So they said, okay, we have to produce a report in 3 months. The president wants it, but there's no money to actually meet. So we're going to have a phone call every Monday, Wednesday, and Friday. So, and some of you know I travel a lot. So I've taken these calls in the weirdest of places on the planet because every Monday, Wednesday, and Friday, there was a phone call because the instructions to Eric Lander and Chris Scheiber, who co-chaired that working group, was we need to have an actionable report in 3 months. We don't need a perfect report. And that was apparently what President Obama had said. And apparently and this is what Chris and Eric had said, that this idea for AMR really came from him. It was not something that the PCAST had put in front of him and said, we'll do a report on this. It's something he said, this is an important problem. Why don't you guys think about this? And if none of you has actually seen this, there's a very nice C-SPAN clip of the president announcing this report, which is online. That's worth looking at because he is so articulate in explaining AMR there, the sense of urgency about the problem, and then explaining the PCAST report itself. And I was stunned thinking, that a president could actually explain AMR as well as any of us here could have, probably much better even. But he was so articulate about that, and he went through all the points, and I got to chair the international working group, for that working group. And we got to put a lot of stuff that I never thought the US would actually take it, seriously, the US government would take seriously. But it all happened. And, we've gone from there to having at least $1 billion. We probably have $2 billion in the federal budget today for AMR, which again is so far considering this all started only in 2015. So I think we've got to credit President Obama for having kicked this off, for of course HHS for having really picked up that ball and run very far with it. I think all the agencies have done so amazingly well. And when I look around at how much progress the world has made, a lot of it has happened here. And I was reflecting on one thing which I think, made a tremendous difference, which again is an idea for us to follow through, at least whoever the next, members of PACCARB are. I think that one of the most influential things that happened immediately when that PCAST report and the action plan was put out, and again, this is something you can find in the White House archives, is as a presidential memo, which created a preference for meat and poultry produced according to responsible antibiotic use policies. Now, we all think of the veterinary feed directive being very important, but if you read this, and this is on the White House website from that time, it was so incredibly far-sighted because it said that if you're a federal cafeteria, most of them, you had to have an antibiotic-free option. And I remember then, the times that we'd go to the HHS building, and remember there was always an antibiotic-free option. That all came down from that one, that one recommendation. And this then got wider, that people understood that there was an antibiotic-free option. And of course, he said, if you can't have that, at least have meat that's been raised responsibly with responsible antibiotic use. So it was that small nudge that I think had an outsized effect, because think of all the federal cafeterias, the military, the educational system, everyone, that nudge really changed the thought process to the point where, back in the day when Jemana would take us out of the building for field trips, I know many of you have never thought that we get to leave the building, but we have done fun field trips here, and some of you have been on those. When we went to, was it Tyson's Food or Purdue, one of them on the Eastern Shore, some undisclosed location where she made us all dress up in moon suits or whatever. And we went in. They said they had been planning for this since 2002, that they knew this was coming, and they had already been planning for it. And that particular facility, as we all recall, raised, some 12 million chickens without any antibiotics whatsoever. So it was possible, but all made possible with these nudges. So I think we've thought about big stuff, we've thought about big connections, but maybe we should spend some time thinking about nudges. What are the smaller things where small changes in policy across the system could have an outsized effect on, it could be on what, CMS does, but it could be certainly on the animal use side, it could be on the environment, but small things that don't necessarily cost a lot of money, is not an injunction to not do something, but really say, listen, if you did things in a responsible way with respect to antibiotics, life may be better for you. So all the best, Jemana, and the rest of the team, and thank you all so much for a great 7 years. Well, tomorrow, Mark.
So, 7.5 years for us with the extension. So clinical pharmacologist worldview of the council. We've done a lot of big picture stuff and a lot of big picture discussions, but there's still time to spend down in the weeds. And we've discussed it before. And this goes in with a larger image of we respond to charges from the people we advise. And I've been a proponent of it before, and I think the council should ask that there be times that we work on projects that just come from the council, that the council derives. And one of those, to me, Clin Pharm, and we've talked about it before, is, there's a lot of room for improvement of regimens of what we use today. After doing some research, I don't think there's much we can do to outthink a resistant bacteria with an altered regimen of an antibiotic that it's resistant to. But there's a lot we can do to minimize development. And when I look on the veterinary side and I look at some of our regimens that are used, some of them are kind of arbitrary. Some of them are really well thought out, but quite a few are really arbitrary. And I would challenge us that perhaps it's the same on the human side. And I think regimens, and if our advice doesn't come down to something a physician or a veterinarian can do in making a regimen decision, I question its utility in ways. And so there's four fingers. I've had to think clinical pharmacology into four things, and it's, can I do some good? Can I do some harm? Can I get it in the patient? What's it cost? All our decision points come down to one of those four fingers, and they're somewhere. And so what we come up with and what we advise on and what we challenge our presenters for, my way of thinking, should come down to those. And maybe can I do some harm becomes environmental. What was the other? Oh, and then I think we should have presenters give us a glossary. Because today we talked about environment, and if I had everyone write down on a piece of paper their definition of environment, it would be incredibly different. Some are, you know, and we talked specifically about water, or we talked about different things, but that part of the communication is so important. And I've had lots of really deep conversations with people only to find out we were talking about something totally different, which happens there. And then the balance side as a veterinarian that is important for the discussion here. And Ramanan mentioned the antibiotic-free chicken. I think those are important. I also think that it's important we balance that with the welfare implications. So as a veterinarian, for example, when people call for antibiotic-free cattle, I think of the foot rots I had in the heifers last year. On our place, we graze heifers and sheep, ewe lambs for a neighbor every year, rotationally graze them. And I think about that if those animals were in an antibiotic-free program, the ones that had pink eye or foot rot, I'd just watch suffer. So there's a balance on there, and I think that's really what we're looking for, is finding that balance where we can protect the animal welfare of those animals and keep that in perspective, while at the same time trying to minimize and optimize our choices. And all the big picture stuff's important, but to me, and what I'm going to do now, people go, what are you going to do with your spare time? Well, let's go back and dive into those actual antibiotic use decisions. And I think this council has time to get down to those weeds and think about that. But yeah, I'm on it through tomorrow at 11 when Joanna gives me the boot, I guess. But I've enjoyed it a lot. And I just mentioned to Joanna the friendships and the people I've met here through this council, and the learning, the incredible learning from having the panelists come in, and then the comments of everyone has just been invaluable. And I'll always remember it. So thank you.
I think we have Virginia Fate online. Virginia, are you there? Yes.
Yeah, I'm here. Thank you. And I'm really
now
sorry.
your turn.
Thanks. I'm sorry I could not be there in person, but I appreciate the ability to listen in all today. And I don't want to repeat what several of you others have said, but one of the things that struck me, and regardless of what the next phase of this council is, or what our next task is that we're assigned or that we make up for ourselves, something that I would like to have us talk about more or hear about more is it's sort of the next, I think of it as a companion to, or the next step of, we had a conversation last meeting about communication and its importance, but the understanding of implementation science, I don't hear us really talk about that very much. I think we are all talking about some of those things, like how do we make the policies work? How do we make recommendations that stick, and all those sorts of things. And I think implementation science might be able to help us with that. I'm not an expert at all, but I think it has the potential to make some of our work more useful, and sort of related to that. And maybe some of you think about these things when you're talking, but we don't say the words of systems thinking. And perhaps you've heard about before, you've talked about this before in other meetings, but the antibiotic resistance and all of the issues related to me are a giant system. One Health is a big system. And if we don't attend to the fact that it is a system, and if we push on one side, another side will, there'll be unintended consequences or intended consequences or whatever. But thinking in a systems approach might also help us think about how we make recommendations and how we write policy and so on. So thank you.
Thanks very much, Virginia. I think everyone's been heard, and I just want to finish us off. First, I want to thank all the presenters for today. As always, they educated us a lot and contributed a lot. For me, this is the 23rd public meeting. We've had innumerable work group meetings and phone calls and emails. I want to thank my partner in crime, Joanna, who's been here since the beginning, and Mike, and really all the colleagues, because it's really been a great group. And everyone has an area of specialty, but I think we've come together to deal with a general problem. And it's a great meeting of the mind, a little like a university. You know, when we started, we had 5 missions. Joanna had to remind me what they were: to slow the emergence of AMR, to improve surveillance in a One Health manner, to develop new diagnostics, to develop new therapeutics, and to improve international efforts. Of course, we weren't going to develop the diagnostics and therapeutics, but we were going to guide that kind of development. And I think that we actually have made a lot of progress in this last 7.5 years. But unfortunately, we still have a ways to go because the problem hasn't gotten any smaller. In fact, it's bigger. So I just have a couple of recommendations. The first, in terms of looking to the future, I was really struck by this issue about the antifungals, that we're using the same antifungals that we need for medicine in agriculture. And it seems to me that we should be able to solve this problem. And probably we can throw enough money at it to solve it. And I think that we should. My second point is that we really have to keep working on stewardship. On the farm and in the outpatient clinic and in the hospital, because we could develop 20 new antibiotics, but they'll all be swallowed up unless we improve how we're using it. And this issue of balance, I think, is really important because it's just not transparent. Doctors and veterinarians and farmers are using antibiotics as if there was no real cost. And of course there is. And my third point, which has been brought up and is in our report, is about the importance of vitalizing and enlarging the work group, the workforce in this area, because we need frontline soldiers in all of these fields. Now, my second to last point is kind of a big picture. Where to go from here. And this is my valedictory. This is kind of looking forward. We're all familiar with climate change, and that I would define as a big change in the macro ecology of the world due to human activities. And I think that antimicrobial resistance is the tip of the iceberg of micro ecological change. Our microecology has been changing for many reasons, especially antibiotics. And the AMR is the tip, but the body is how we are affecting the human microbiome. And also the plant microbiome and the animal microbiome. I'm most familiar with the human microbiome. And it's clear that antibiotics change the microbiome. It can be transient, it can be long-term. It changes the balance in the body in terms of metabolism, immunity, cognition, and the ability to resist pathogens. It's paradoxical that antibiotic use makes us more susceptible to further infections. And so there are a lot of clinical consequences from this. And to me, going forward, this is the big frontier. This is where AMR alone is a big issue, but this is even a bigger issue. So as everyone has said, we have to use communication and keep building trust. That's our only way to be effective. And so as part of my valedictory, I want to thank everybody. It's been a great 7.5 years and innumerable meetings. But it's been very enjoyable, and thank you to everyone. And I think now it's time for our closing remarks. Mike, you have any closing remarks?
I think those were them.
And with the lateness of the hour and the still possibility of seeing some sunlight, this meeting is adjourned. And we will reconvene tomorrow. Thank you.
Produced by the U.S. Department of Health and Human Services.